All right, buckle up, everyone, because today we're taking a deep dive into something pretty sneaky, primary aldosteronism.
Ooh, that sounds interesting.
It is, it is.
Yeah.
It all comes down to your adrenal glands, those little glands that sit on top of your kidneys.
Right.
Well, they can sometimes decide to go a little rogue and start churning out way too much aldosterone.
Aldosterone, huh? That's a hormone, right?
It is. It's a big player in how your body handles salt and potassium, keeping everything balanced just right.
Balance is key, for sure. But what happens when things get out of whack?
That's the thing with primary aldosteronism. The classic symptoms you might expect, they don't always show up.
Really? So it's kind of a silent troublemaker.
Exactly. It can be super tough to catch. And that's what we're going to unravel today, using some fascinating excerpts from pasted text as our guide.
Sounds like we have a real medical mystery on our hands.
We do, we do. And thankfully, we have an expert to help us navigate this tricky terrain. Welcome to the show. I'm so glad you could join us.
Thanks for having me. Happy to be here.
So, just to back up a bit, for anyone who might not be familiar with this hormone, could you give us a quick rundown of what aldosterone does in the body?
Sure thing. So think about your kidneys like a super sophisticated filter system.
Okay, I can visualize that.
Aldosterone's main job is to tell those kidneys to hang on to sodium, salt.
Right, got it.
But here's the kicker. That's sodium retention. It triggers a whole chain reaction.
Like a domino effect.
Yeah, pretty much. It starts messing with potassium levels, and it even goes as far as creating this electrical gradient in your kidneys.
An electrical gradient.
Yep. It's super important for how your kidneys function properly.
Wow, so it's not just about sodium. Aldosterone has this ripple effect throughout the body.
Exactly. And what's so fascinating is that even when things go off the rails, like with primary aldosteronism where you have too much aldosterone, your body tries to compensate.
Compensate? How so?
It's like it tries to find a new equilibrium.
So it's trying to establish a new normal even though things are out of balance?
Precisely. Your sodium and potassium levels might jump up at first, but then they kind of settle at these new higher levels. And get this, your body adjusts so that the amount of these electrolytes you pee out matches what you're taking in through your diet.
So the body is constantly striving for that balance, even in the face of all this extra aldosterone. When I think about sodium and water retention, the first thing that pops into my mind is, well, swollen ankles edema.
Yeah, I can see why you'd think that.
But I've read that edema isn't always a given with primary aldosteronism. Why is that?
That's a great question. And it all boils down to something called aldosterone escape.
Aldosterone escape. Okay, tell me.
So initially you do get that sodium and water buildup, right?
Right.
But then your body's like, hold on a second, we need to fight back.
Yeah.
It releases this hormone called atrial natriuretic peptide.
Try saying that 3 times fast.
I know, right? Atrial natriuretic peptide, or ANP for short. ANP basically tells your kidneys, hey, let's get rid of some of this excess sodium and water. And to add to that, the pressure inside your blood vessels increases, which also forces your kidneys to flush out more fluid.
So it's like a two-pronged attack, AMP and higher pressure working together to counteract that fluid retention.
You got it.
But if the body is getting rid of that excess, why is high blood pressure still such a hallmark of primary aldosteronism?
That's the tricky part. Even with that escape mechanism, that initial flood of fluid volume is enough to set off the hypertension.
It's like the initial shock to the system.
Exactly. And it's not just the aldosterone itself causing the problem, but the sheer volume of fluid circulating in your system. Plus, you also get increased systemic vascular resistance.
Meaning?
Meaning your blood vessels start constricting more, which just cranks up the pressure even further.
Okay, so it's this complex interplay of factors. Now, I want to touch on something that really surprised me. We often hear about low potassium or hypokalemia as a common symptom.
Yeah, it's definitely a common association.
But you're saying it's not always present.
You're right on the money. While hypokalemia is common, it's not a universal finding in primary aldosteronism.
So not everyone with this condition has low potassium.
Not at all. We're actually seeing more and more patients who have normal potassium levels. We call it normokalemic primary aldosteronism.
That seems counterintuitive. If aldosterone makes you retain sodium, shouldn't it also be driving potassium down?
You'd think so, right? But it's not always as straightforward. There are other factors in play.
Like what?
Well, for example, there are genetic conditions like glucocorticoid remediable aldosteronism.
Say that 10 times fast.
Uh-huh. I know, it's a mouthful. We usually just call it GRA for short.
Okay, GRA.
And there's another one called Little's syndrome. In these conditions, genetic mutations can lead to primary aldosteronism, but without that typical hypokalemia.
So in those cases, it's not just about the amount of aldosterone, but how your kidneys are responding to it.
Exactly. Genetics can really throw a wrench in the works.
Fascinating. So what about cases where genetics aren't involved? How do we explain normal potassium levels then?
That's the million-dollar question that researchers are still trying to figure out.
Really, it's still a mystery.
To some extent, yes. We know aldosterone isn't the only player in this potassium game. Things like how much potassium you're getting in your diet, other hormones like insulin, even individual variations in how well your kidneys function can all impact your potassium levels.
It sounds like there's still so much to learn about the nuances of potassium balance. Okay, so we've covered sodium, potassium, and blood pressure. But primary aldosteronism doesn't stop there, right? What other impacts should we be watching out for?
You're right, it can affect much more than you might think. One thing to consider is metabolic alkalosis.
Metabolic alkalosis, what's that?
It's basically a condition where your blood becomes too alkaline. And that low potassium we were talking about, it actually plays a role here.
Really? How so?
When your potassium is low, your kidneys start hanging on to more hydrogen ions.
Those are acidic, right?
Exactly. And that makes your blood more alkaline. And to make matters worse, aldosterone itself directly increases hydrogen excretion.
So it's a double whammy on your body's pH balance?
You could say that.
Wow. Okay, so metabolic alkalosis is one thing to watch out for. Are there any other sneaky effects of primary aldosteronism that we might not immediately connect to the condition?
Oh, absolutely. Let's talk about the kidneys for a second.
The kidneys, okay.
You might be surprised to hear that primary aldosteronism can actually increase your glomerular filtration rate, or GFR for short.
GFR. Remind me what that is again?
It's basically a measure of how well your kidneys are filtering waste from your blood.
Okay, right.
And primary aldosteronism also increases renal perfusion pressure.
Renal perfusion pressure. That's the pressure of blood flow through the kidneys, right?
You got it?
Wait, really? I would have thought it would have the opposite effect, like it's putting more strain on the kidneys.
It seems counterintuitive, I know. But this increased GFR and renal perfusion pressure can actually mask underlying kidney problems.
So it's like a disguise.
Kind of. It's like your kidneys are putting on a show, making it look like they're functioning better than they actually are.
Yeah.
But the good news is these changes are often reversible with treatment.
So addressing the primary aldosteronism is crucial for protecting those kidneys long term.
Absolutely.
That makes sense. Now, I know muscle weakness is often associated with low potassium. Is that something that people with primary aldosteronism experience?
Yes, muscle weakness can definitely be a symptom, and it mainly stems from low potassium. But it's usually only severe in those extreme cases where potassium levels are really depleted.
Okay, that's good to know. What about the heart, though? Does primary aldosteronism impact cardiovascular health?
This is a critical point, and the answer is a resounding yes. Primary aldosteronism significantly increases your risk of cardiovascular problems.
Really? Even compared to other types of high blood pressure?
Even then. Studies have shown that people with primary aldosteronism tend to have thicker heart muscle, which means their hearts are working harder than they should be.
I imagine that extra strain can lead to some serious issues down the line.
Exactly. People with primary aldosteronism have a higher risk of strokes, heart attacks, and atrial fibrillation, which is a type of irregular heartbeat. But here's the silver lining. Treatment can drastically reduce this risk.
That's a crucial point to highlight. Early diagnosis and treatment can make a world of difference when it comes to protecting your heart.
I couldn't agree more.
So why does primary aldosteronism have such a powerful effect on the cardiovascular system?
Well, to really understand that, we need to dive a bit deeper into the science. There's growing evidence that mineralocorticoid receptors, those are the receptors that aldosterone binds to.
Right.
They're actually present in the heart and blood vessels themselves.
So it's not just the indirect effects of high blood pressure or low potassium. Aldosterone is directly impacting these organs.
Precisely. It seems that the activation of these mineralocorticoid receptors in the heart and blood vessels actually contributes to the damage we see, even regardless of potassium levels. When aldosterone binds to these receptors, it can trigger inflammation and fibrosis, which is basically a thickening and scarring of the tissues, and that weakens the heart and blood vessels, making them more vulnerable to damage.
Wow, this is way more than just a blood pressure issue. Primary aldosteronism has far-reaching consequences.
You said it. And that's why early detection and proper management are so crucial.
Well, this has been incredibly eye-opening. Thank you so much for breaking all of that down for us.
My pleasure. Glad to be here. So we've seen how sneaky this primary aldosteronism can be, right? Affecting you in ways you might not even realize.
Totally. It's like this silent operator in your body kind of wreaking havoc behind the scenes.
Exactly.
That's why I'm really curious to dig into the diagnostic side of things. What makes primary aldosteronism so difficult to catch?
Well, one of the biggest hurdles is that the symptoms are often, well, pretty subtle, especially in those early stages.
Okay, that makes sense.
And remember, not everyone experiences that classic low potassium.
Right.
Right?
Right.
So you might just have high blood pressure, which is, let's face it, incredibly common and easily attributed to other things, like your lifestyle, genetics.
So it's like searching for a tiny crack in a huge dam. You know something's not quite right, but pinpointing the exact source of the problem is a whole other story.
That's a great analogy. And even when someone does have low potassium, there are so many potential causes, right? So primary aldosteronism isn't always the first thing that comes to mind. It's like solving a medical mystery, really. You have to piece together all the clues: the patient's history, physical exam.
And blood tests, I'm guessing.
Oh, absolutely. Blood tests are key.
So what are we looking for specifically in those blood tests?
The key is to zero in on the levels of aldosterone and renin.
Renin.
It's an enzyme that helps regulate aldosterone production. It's all about the balance between these two.
So if someone has high aldosterone but low renin, that's a red flag.
That's a classic sign, yep. It tells us that the aldosterone production is autonomous.
Autonomous, meaning?
Meaning it's not responding to the normal feedback mechanisms in the body. Think of it like a car that's stuck with the accelerator pedal jammed down no matter what.
Okay, I get it. But even with those blood test results, conferring a diagnosis isn't always straightforward, right?
You're absolutely right. There are a number of confirmation tests that might be needed, and the specific test we use often depends on the individual case.
So what are some of these confirmation tests?
Well, one common one is the saline infusion test.
Saline infusion, what does that involve?
It's pretty simple, really. We basically infuse a saline solution into the bloodstream, and then we carefully measure the aldosterone levels.
Okay, and what does that tell us?
Well, in someone without primary aldosteronism, that saline infusion would suppress aldosterone production. But in someone with the condition, those levels would stay high. It confirms that something's causing their adrenal glands to overproduce the hormone.
So it's like testing the body's natural braking system.
Exactly. And there are other tests, too, like the fludrocortisone suppression test.
What's that one?
It uses a medication to try and suppress aldosterone. Again, it's all about challenging the system and seeing how it responds.
So it's a bit of detective work, using these different tests to uncover the root of the problem.
I could say that.
So let's say we've confirmed a diagnosis of primary aldosteronism. What are the treatment options?
Well, the treatment really depends on the underlying cause. If it's caused by an aldosterone-producing adenoma, which is a benign tumor in one of the adrenal glands, surgery is often the most effective approach.
So in those cases, it's possible to actually cure primary aldosteronism.
In many cases, yes. Laparoscopic adrenalectomy, which is a minimally invasive surgery, has become the gold standard for removing these adenomas.
That's good to hear. But what about the situations where surgery isn't an option, or if the cause isn't an adenoma?
That's where medications come in. Mineralocorticoid receptor antagonists, also known as aldosterone blockers, are usually the first line of treatment.
Aldosterone blockers, what do they do?
They essentially block the effects of aldosterone, preventing it from binding to its target tissues. This helps lower blood pressure and correct any electrolyte imbalances.
So it's like putting up a shield to protect the body from all that extra aldosterone.
Exactly. Spironolactone and eplerenone are two commonly used aldosterone blockers, and they're quite effective in managing the symptoms and reducing those long-term risks associated with primary aldosteronism.
This is all incredibly important information, especially for anyone who might be at risk.
I agree.
It really highlights how crucial early detection and proper management are.
Couldn't agree more. And it's not just about symptom management either. Treating primary aldosteronism can actually reverse some of the damage that's already been done, particularly to the heart and blood vessels.
Wow, so there's a real chance to undo some of those negative impacts.
That's right.
That's encouraging. It really underscores the importance of seeking medical attention if you have any suspicions at all.
Absolutely. And remember, primary aldosteronism is a chronic condition, so ongoing monitoring and management are essential.
So it's about building that long-term partnership with your healthcare team.
Exactly. Open communication, regular checkups, and sticking to your medication plan are all vital for keeping primary aldosteronism under control and living a healthy life.
Well, this has been incredibly insightful. So far, we've covered the basics, the symptoms, the diagnosis, the treatment. But the world of medicine is always evolving, right?
It certainly is. And when it comes to primary aldosteronism, there's some really exciting research happening right now. Research that could change how we approach this condition altogether.
I'm all ears. Let's dive into that cutting edge research. So let's talk about that cutting edge research. What kind of breakthroughs are researchers looking at when it comes to primary aldosteronism?
There's some very promising stuff on the horizon, both for diagnosis and treatment. On the diagnostic front, there's a lot of focus on developing more sensitive and specific screening tools.
That makes sense, especially since we talked about how subtle the symptoms can be.
Exactly. So one exciting area is the investigation of novel biomarkers.
Biomarkers? What are those?
These are basically molecules that can act as indicators for specific conditions. Instead of just relying on aldosterone and renin levels, we could have other clues to help us pinpoint primary aldosteronism more accurately.
So it's like having more pieces of the puzzle to create a clearer picture.
Exactly.
What kind of biomarkers are they looking at?
Researchers are exploring all sorts of things. Specific proteins found in the blood, even genetic markers. The idea is that these markers could give us more detailed information about what's happening in those adrenal glands and how they're responding to aldosterone.
It sounds like these biomarkers could be real game changers for early detection.
I think so too. And then on the treatment side, there's a lot of interest in developing more targeted therapies.
Targeted therapies.
Yeah, particularly for those who don't respond well to the traditional aldosterone blockers. One promising avenue is targeting specific enzymes that are involved in aldosterone synthesis.
So instead of just blocking the effects of aldosterone, these therapies would actually prevent it from being produced in the first place.
You got it. By inhibiting the enzymes responsible for making aldosterone, we could potentially lower those levels more effectively.
That sounds really promising. Are there any other new approaches being explored?
There are. Some researchers are even looking into gene therapy.
Gene therapy for primary aldosteronism.
Yep. It sounds pretty futuristic, I know, but it's a testament to how far medical science has come. Imagine being able to correct the genetic mutations that drive this condition, essentially curing it at its root.
That would be incredible. It sounds like there's a lot to be hopeful about when it comes to the future of primary aldosteronism treatment.
Absolutely. The research is moving fast, and I'm optimistic that we'll see some major advances in both diagnosis and treatment in the coming years.
Well, this has been an incredibly fascinating deep dive into primary aldosteronism. We've explored everything from the basic mechanisms to the newest research, and it feels like we've just scratched the surface.
It's been a pleasure to be here and shed some light on this often overlooked condition.
And for our listeners, I hope you've learned something new today. Knowledge is power when it comes to your health. If you have any concerns or questions, don't hesitate to talk to your doctor.
And never underestimate the importance of advocating for your own well-being. Stay informed, ask those questions, and be proactive about your health.
That's a great takeaway. Thanks so much for joining us today. And to all our listeners, thanks for tuning in to our deep dive into primary aldosteronism. We'll see you next time for another exciting exploration into the world of science and medicine.